We've covered 6,000 manuscripts, dissected out of that the 120 autopsy cases. Now we have morbidities, and on this slide I say they're too numerous to count. And a fatal Herxheimer reaction developed after treatment with high doses of penicillin caused by relapsing fever Borrelia. So sometimes treatment of an overwhelming infection without support of patients with antibiotics and steroids can lead to death because the treatment causes toxic products to be released into the blood as the spirochetes are killed, and the toxic products may kill the patient. So the Herxheimer reaction is something to be managed very, very carefully. Here's a case from the Annals of Rheumatic Disease, and it's Borrelia isolated from the cerebrospinal fluid in a French case of Lyme disease, 46-year-old patient, tick bites, neuritis, meningoradiculitis. A pacemaker was required to manage the myocarditis. We know about myocarditis. Here's a paper from 2012, and it's Future Virology, volume 7, page 885 by Beaver, describing HSV virus and axonal transport of the virus in Alzheimer's disease, in vitro and in vivo evidence for causal relationships. So here we're talking about herpes virus, which may have a role in causing dementia of the Alzheimer type, and further describing a method where the virus jumps from nerve to nerve and travels inside the nerve along axons. Here is a case from 2009 by Parent. The case for chronic infection, evidential persistence of Borrelia species post-antibiotic exposure in vitro and in vivo. This paper then warns us that antibiotics may not kill the Borrelia. They may persist after antibiotic therapy has been continued and then ceases. We've seen cases in our study where patients received antibiotics, improved their dementia status, antibiotics were stopped, the patients went on to die. So we have that from the evidence-based part of our lectures in Lecture 1 and 2. Here's a case of latent Lyme neuroborreliosis from Dr. Pfister in Neurology, 1989, volume 39, page 1118. Latent neuroborreliosis, presence of Borrelia burgdorferi in spinal fluid without any inflammation, without concurrent inflammatory signs. So the spirochetes in the spinal fluid, and there's absolutely no inflammation. Dr. Pfister is one of the leading world experts on Lyme disease from Germany. Here's a case of fatal myocarditis, progress in cardiac diseases, 2010. Acute myocarditis has been shown to cause sudden death in up to 12% of cases in autopsy series. Well, we know from the CDC report that Lyme myocarditis can cause sudden death in the 3 cases that we began to discuss in the first lecture. Syphilis and borreliosis in pregnancy, comparing the syphilitic pregnancy outcomes with the Lyme disease outcomes. This is from Dermatologic Therapy, year 2008, volume 21, page 205. The Johns Hopkins Medical School reports, quote, court grants autopsy in connection with a suspected case of Lyme disease. Sometimes you have to go to court to have a forensic autopsy to get the evidence either for or against Lyme disease. All right, let's see what else we have here in this folder. This is a pack of additional case reports. This is eye problems in 1993 by Nuta, and it's in the Annals of Ophthalmology, volume 25, page 257. Monolateral chorioretinitis with multiple foci in one case of Lyme disease. Neuroretinitis, 2009, associated with serologic positivity for Borrelia and Bartonella henselae. Bartonella henselae is another co-infection that can co-travel with Borrelia burgdorferi. This is in retinal cases and brief reports, volume 3, page 243 in year 2009. In 1989, Kohler, Lyme borreliosis, a case of transverse myelitis with syrinx cavity. Now, when the spinal cord is inflamed such that signals from the top to the bottom of the cord are blocked by inflammation or disease, it's called transverse myelitis. And it produces syndromes of paralysis, lower legs, or worse. When there's more damage to the inflammation, a cavity forms, and instead of having solid spinal cord, you have a fluid cavity which is not supposed to exist in the spinal cord. That's a syrinx cavity. This is Lyme borreliosis producing transverse myelitis and a syrinx cavity. Very, very serious problem. Lyme borreliosis, different ocular aspects of the same disease in the northwest of Italy, from Allegri, Acta Ophthalmologia, volume 86, year 2008. Borrelia-associated crystalline keratopathy with intracorneal detection of Borrelia guerini in electron microscopy and polymerase chain reaction, from the journal Cornea, volume 27, page 2008. So these are all ophthalmologic papers relating to complications in the eye related to Lyme infection. Let's see what else we can find in here. Harvey and Martz, motor neuron disease recovery associated with IV ceftriaxone and antibiotic therapy. Acta Neurologica Scandinavia, volume 115, year 2007. Now, Dr. David Martz had diagnosis of Lou Gehrig's disease, and that meant that his doctor told him he was going to die. He made plans to die, and he sought care and found Dr. Bill Harvey. Dr. Harvey treated Dr. Martz with IV ceftriaxone high doses for a period of years, and combination therapy was rotated, and Dr. Martz had periods of resting between getting IV antibiotics. And the bottom line is that 15 years later, Dr. Martz is alive and well and running an ALS clinic to treat Lyme-like or ALS-like Lyme in Colorado Springs, Colorado. He has 900 patients. He has results where he's cured at least 12 to 15 patients. That's unheard of in motor neuron disease. Let's see here. Croatia, chronic Lyme neuroborreliosis and psychosis. Remember that the psychiatric and neuropsychiatric field is a huge field, and when the brain is involved, as you know it is in Lyme disease infections, many psychiatric and neuropsychiatric conditions can occur. This report from the Collegium of Anthropologic, volume 35, page 313, 2011, reports such an event. Here's one from 2011. Postural orthostatic tachycardia syndrome following Lyme disease. That means that as you change from seating to standing or from lying to sitting, your blood pressure drops to a very low level. That's called orthostatic postural hypotension, and that's due to Lyme disease infecting the autonomic nervous system. This in Cardiology Journal, volume 2011, page, volume 18, page 63 to 66. They used the tilt table test to evaluate such patients. They had 5 cases that they reported. They came in with other symptoms like migraine, anxiety, depression, and evidence in some cases of high blood pressure and low blood pressure. These symptoms would be then sometimes dismissed by doctors as being undiagnosable or due to conditions that could never be Lyme disease because Everybody knows that Lyme disease is supposed to be the red skin patch, the swollen joint, the facial nerve droop, the heart block, and the meningitis. And anything outside of those four areas is not acceptable as Lyme disease. Well, this dossier of chronic Lyme disease cases written from authors around the world tells a different story. And the full geography, the medical arena of Lyme disease continues to grow. I don't have time to go through all of these cases, but I will. Just like I went through 6,000 cases to find 120 autopsy cases to show you that Lyme disease is a chronic medical situation. We've had a quick survey of Lyme borreliosis disability, chronic disease in organ systems which you would never imagine to be related to Lyme, morbidities, loss of vision, threatening diseases such as Lou Gehrig's disease, which is a life-ending disease which never ever gets better on its own. Never is there a recovery from Lou Gehrig's disease. But in Lyme-like motor neuron disease or Lou Gehrig's disease, Lyme-like type, there is a cure of some patients with high-dose antibiotic therapy over long periods of time. These are sobering and new ideas that have to be thought of in terms of what is chronic Lyme borreliosis, what is the domain of the doctor who's responsible for the patient in figuring out what is going on with the patient, and if antibiotics are indicated for Lyme, for God's sakes, give the patient a chance. Now, inflammatory deaths, we have shown in childhood and adults can cause deaths verified by autopsy due to Lyme disease. Stroke deaths, we have shown in Europe. They're way ahead of us and in the US, and Borrelia and stroke in many, many cases are related to cerebral vasculitis. That's inflammation of the blood vessels and ongoing Lyme infection. So you treat them with both steroids and antibiotics. We've shown that Borrelia in childhood can cause adolescent deaths. We don't have registries, so we don't have good totals for this, but children can die of Lyme disease just as adults and elderly can die of Lyme disease, and fetuses can die of Lyme disease. It's a great tragedy when there's a death in childhood or adolescence due to Lyme infection. We've shown demyelination and multiple sclerosis deaths and morbidities, so you can wind up in a wheelchair if you have demyelination, and if the demyelination is due to Lyme infection, the antibiotics may be able to get you out of that wheelchair. We hope for this opportunity to be tested and to be realized in people who have demyelination forms of multiple sclerosis. Spinal fluid studies are essential, and they will be helpful in diagnosing this condition. We've shown you pulmonary deaths, acute fetal respiratory distress leading to death, and acute respiratory distress in adults. Shown you fetal and neonatal deaths where there's miscarriage and death, or where there's death shortly after birth. We've shown you Parkinsonian disease with death confirmed by autopsy to be Lyme disease in the brain. We've shown you dementia deaths, and Dr. McCloskey and I are the only pathologists other than a few now who are coming in. Dr. Meir is not a pathologist, but she got some pathologic help in reporting her case. And now there are established cases of infection-related dementia of the Alzheimer type. In the Journal of Epidemiology, they had an article which was a review article and was devoted to the topic, can infections cause dementia? And they concluded yes. And they said that in that article by Dr. Mawanda and colleagues, that the amount of evidence is so enormous at this point that it is impossible to continue to ignore it. Although proof is not presently at hand, they are examining Lyme disease as cause of human dementia, along with other infections such as chlamydia and herpes simplex virus infections. The enormity of evidence is too large to continue to ignore. Journal of Epidemiology, Dr. Mwanda. Motor neuron disease, I mentioned Dr. David Martz and his triumph over a death sentence, Lou Gehrig's disease. He has a clinic in Colorado Springs. He's had 900 cases so far, and he's been able to cure maybe 13 of them. They're offered antibiotics if they are seropositive. We've seen sudden infant death due to Lyme disease, and I have 2 cases in my collection. I hope to see more to study. Renal deaths, we don't have human renal deaths, but we have canine renal deaths. Now, animals are sentinels. Sentinels are like the canary in the coal mine. And animals then, if they develop a disease, which is transmitted by ticks, and the same tick also bites humans, animals tell us that we should start to look for the disease that is seen in dogs when we look at humans with kidney disease. We have not begun to do that in a systematic way. We need to do that and make some progress there. We've seen Lyme disease with multiple co-infections. So we've seen Bartonella and Lyme disease. We've seen virus, tick-borne encephalitis and Lyme disease. And we've seen Babesia and Lyme disease. To that list, we can add others such as Coxiella, Burnetii, Ehrlichia, and Anaplasma phagocytophilum. If you are dealing with a Lyme disease case, you must be prepared to deal with multiple co-infections. So it may not just be one infection that you have to treat. You have to investigate all of the other possible co-infections. They are treated differently from Lyme disease. They require different antimicrobial agents, and it just gets complicated. It also gets to be a chronic situation because you can't administer them all at once. You have to give the patient time to recover and space them apart to give the patient some rest periods. You don't want to have a Herxheimer reaction that kills the patient because your antimicrobials are eliminating bugs in the system, but toxic products come from killing the bugs, and these toxic products can cause shock and death in the Herxheimer reaction. You do not want to have a fatal Herxheimer as a result of your good attempt to try to cure a patient with antibiotic therapy. You must watch them very, very carefully and support them, if necessary, with hospital admission. Forensic autopsies are coming to the fore. We have 3 so far. They were court-ordered because doctors did not want to believe in some situations that the patient died of Lyme disease. In other situations, there was an unknown death, such as the 3 cases in the CDC series. Forensic medical examiners are physicians, pathologists, trained in advanced forensic techniques, and they are now picking up cases of unsuspected Lyme disease as a cause of sudden death. Relapsing fever borreliosis has produced deaths since the 1900s in Africa. There are no registries. It continues to produce deaths in the third world. It is the first cousin of Lyme disease. So people who say, well, Lyme disease has never been proven to be associated with fetal death are very incorrect. They are unaware of the relapsing fever statistics, where it kills fetuses in great number in the third world. They are unfamiliar with syphilis, which had excess death in pregnancy, and fetuses, either stillborn or miscarried fetuses, died as a result of syphilitic infection acquired from mother, transmitted across the placenta to the baby. Lyme disease can do what relapsing fever can do and what syphilis can do. It can kill babies in utero as miscarriage, or it can kill babies at term and stillbirth, or it can kill babies who look healthy at birth and after they are born then pass away in 3 months of age in sudden infant death. Transplantation transmitted Lyme disease is a concern. We haven't seen it yet, but we came very, very close with the CDC 3 cases. Each one of those patients was a transplant harvest patient, and if the forensic pathologist had not intervened, those organs would have been transplanted into people. There is the issue of blood transfusion. Is Lyme disease present in the blood of some well-meaning blood donors who don't have symptoms? If that blood is infected and if it's transfused, will that blood cause problems? We know that for Babesia infections, which are transmitted by blood transfusions, there have been deaths from transfusion. And because there have been deaths proven to be Babesia, proven to be transmitted by transfusion, the CDC now has a registry to follow Babesia infections and transfusion deaths, and steps are being taken to detect Babesia in units of blood so that they are not transfused. We need to do a similar program with Borrelia because we do not want to have adverse outcomes. We need to do a similar program with Bartonella because we do not want to have adverse outcomes of blood transfusion from well-meaning blood donors who don't have symptoms but whose blood is bad, the blood is infected. Miyamotoi. Miyamotoi Borrelia is something that is now in the public eye. It has never really been a focus over the past 30 years, but it popped up in New Jersey recently and caused a serious illness in the brain of a patient. I think that Miyamotoi has always been among us. As we look for Miyamotoi, we see it in many states in the United States. We see it across Europe. Miyamotoi is a relapsing fever like Borrelia. Problem is there's no blood test for it, and the problem is you can't grow it. Among my autopsy series, I went back and honestly looked to see whether any of the things that I called Borrelia fetal deaths could have been Miyamotoi fetal deaths. And I found one case, and here it is. It's a baby that died. It has a spirochete, which you can see coming across the field, and it has three round glowing bodies. This is monoclonal 9724, and the 9724 monoclonal outlines only Borrelia proteins. So this is a Borrelia, 9724 positive. This is a cystic Borrelia, 9724 positive, and this is another cystic Borrelia, 9724 positive. I have looked at this case for 25 years, and it took me about 20 years to get the truth that, in addition to this spirochete in my brain of the baby that died and had the 9724 monoclonal that picks up Borrelia Miyamotoi and Borrelia burgdorferi, that these round things were cystic Borrelia. And therefore, cystic Borrelia need to have more attention because they are just as legitimate when they bind monoclonal antibodies as are the spirochetal forms. Linkages, Borrelia, chronic morbidities. We have cardiomyopathies, dilated type, blindness, permanent nerve dysfunctions. You know, they say that the facial palsy of Lyme disease is always reversible with antibiotics. That's not true. Some people who have a Lyme disease seventh nerve or facial Bell's palsy never recover function of that nerve, and they have a permanent droop for the rest of their life. There are peripheral nerve problems that are also related to Borrelia infection, and autonomic nerve problems which cause those blood pressure, orthostatic hypotension cases that I talked about, tilt table positive cases. Malignant lymphomas of the B cell type, T cell type, and malignant plasma cell tumors are all linked in some cases to Borrelia infections. Squamous cell cancer has arisen from acrodermatitis chronica atropicans. Everybody knows in Europe that ACA, acrodermatitis chronica atropicans, is the perfect example of very late chronic Lyme disease. From this skin, which has been chronically infected with Borrelia, tumors arise. And in addition to squamous cell cancer coming right out of the center of an ACA lesion, there have been malignant lymphomas coming out of the center of an ACA lesion. Multiple sclerosis and demyelinating diseases are now on the map as related to Borrelia infection in some patients. Motor neuron diseases are now on the map. And one of the clues that Dr. Martz has pointed out in his lecture is that if you're diagnosed with motor neuron disease, or ALS, and you have coexistent pain in your body, that is not the usual ALS. Lyme disease related ALS-like illness, motor neuron diseases, often has coexistent pain. ALS of the type which is not related to infection, not related to Lyme, never ever has pain. So if your patients have pain plus motor neuron disease, think very long and hard about the possibility of Lyme disease as the cause of the motor neuron disease symptoms. Gastrointestinal dysfunctions, motility disorders. This comes under the category of autonomic nerves, which are Diseased and autonomic nerves govern motility, gastrointestinal tract. Some people call these motility disorders Bell's palsy of the gut. And in a way, that's a good way of thinking about it. The autonomic nerves are diseased. The gut slows down. Sometimes the gut stops pumping the intestinal contents altogether. The patient may go into a condition called ileus, and then the wall of the bowel may break down. The patient may die of sepsis. So it's a very serious, potentially serious condition. Teratogenic effects, that's the birth defect scenario. We discussed that. That needs to be proven, but there are many, many cases, I think too many, in the Lyme fetal autopsy category where there are holes in the heart, far more than you would see by just chance alone if you do a fetal autopsy. The problem is that fetal autopsies are not done, and I am not aware that a full fetal autopsy is done by pathologists here in the United States or elsewhere. What usually happens is the fetus that is a small human being comes into the lab. It's a miscarried fetus. It's weighed. They look to see if there's any external malformations. They measure the foot length, and then they describe it and do not even do microscopic sections. Hydrocephalus is an example of Lyme-related injury. We've had fetal hydrocephalus. We have adult hydrocephalus. Giant cell arteritis. This is something that I first described with Dr. Pizzarello in 1987. Temporal arteritis. They've now found cases of Lyme temporal arteritis at the Karolinska Institute, a premier medical world-renowned facility. They referred to our paper. It took about 20 years for them to catch up to us in Southampton. We described the first case. Osteomyelitis, that's infection of the bone. Endocarditis, infection of heart valves. 2 cases now well proven with PCR and DNA studies. Afzalii endocarditis from Borrelia in France and in Strasbourg, and a Baceti in the Czech Republic, endocarditis of Lyme type. Spondylitis syndromes, that's like ankylosing spondylitis or Marie Strimple disease, where the spine becomes very rigid and painful. That has been described in relation to chronic Lyme infection. So this is the type of Lyme disability morbidity. Endocrine dysfunctions. More and more endocrine dysfunctions are being described. Pituitary, thyroid, and adrenal are the ones that are most prominently mentioned. And so somebody who comes into your office with a thyroid problem and pain in the body, a Lyme type pain, or a thyroid problem plus arthritis, might have one of these couplets of symptoms, and that is 2 symptoms that don't necessarily connect in any way that we can understand in the usual medical thought process, but they are a manifestation of Lyme infection. Couplets or triplets of symptoms in various organ system diseases. Striatonodal degenerations, that's a big name for Parkinson's-like change, Parkinson's-like Lyme disease, which we have proven at autopsy. We're seeing now more cases of Lyme-related Parkinsonism in the United States. Some Lyme Parkinsonism cases have dementia associated with them, some do not. Dementia of the Alzheimer type. This is something that I put on the map in 1985-86, and Dr. McCloskey has done tremendous work in this area. We both believe that Alzheimer-like changes can occur in spirochetal infections of the brain. She's got experience with both Borrelia causing this change and Treponema spirochetes in the oral cavity causing this change. Dr. Andrew Dwork, as we mentioned, showed frontal dementia and Lyme disease spirochetes in the brain at autopsy. I have 1 case of dementia of cortical Lewy body type with positive DNA probes showing Lyme infection in that case. So Parkinson's disease with or without dementia. I'm looking actively at cortical basal degeneration and Pick's disease, 2 other neurologic degenerative diseases of unknown cause, as possible areas of fertile research for Lyme-related neurodegeneration. So to do a spirochetal focused autopsy, you need to have some skills and you need to have some reagents. I'm going to go into great detail in my addresses in London and in Oslo, so I won't describe these in detail here. If I did, there'd be no reason for you to go to Oslo or London to hear me speak. But this gives a list of techniques which I will describe, which I have developed to help pick up Borrelia spirochetes in autopsy tissue. These are sophisticated techniques, and they require practice, and they require some special reagents. Once learned, they are not that tedious to apply, and they give a swift and sure answer to the question, is this Lyme disease in autopsy material or is it not? We'll be looking for equivalents of this image, which we had originally with the CDC, where we see spirochetes in tissue, or whether we see spirochetal DNA in tissue. We know that inflammation in and of itself is not helpful. Lots of things can cause inflammation. There are no specific inflammatory patterns for Lyme disease in any organ system in the body. There are also the non-inflammatory types of Lyme disease in the fetus, where there is no inflammation, but there are spirochetes in tissue. So inflammation is not our friend, and lack of inflammation is not our friend either. Spirochetes and the spirochetal DNA are the only things that are good evidence for Lyme in the death. The spirochetal DNA-focused autopsy I will describe in more detail in Oslo and London, and it can be applied to various specimens, body tissues, ground specimens, digests of tissue, and polymerase chain reaction of DNA from autopsy tissue. False fears. Some pathologists, if they hear that there could be Lyme disease, refuse to do the autopsy. They say, I don't want to become infected. This is not a valid reason to decline to do an autopsy for suspected Lyme disease or for any infectious disease whatsoever. Even Creutzfeldt-Jakob disease requires spacesuit type protection, but Creutzfeldt-Jakob disease is the responsibility of the pathologist to obtain tissue to confirm the diagnosis for public health reasons. And so the pathologist does not have an exit strategy from doing an autopsy. To step back and refuse is unprofessional and is condemned by the specialty of pathologists. Forensic autopsies, very helpful. We have the Australian case, CDC case, Suffolk County Medical Examiner case. Other cases will follow. Cultures. We do special techniques to try to grow the Borrelia from tissue. And you've seen that not only I, but pathologists in other countries have grown Borrelia from autopsy tissue. And that has helped to make the diagnosis of Borrelia infection as the cause of death. You can also cultivate blood, cerebrospinal fluid, ticks, and small cubes of frozen autopsy tissue, which are thawed and placed into either BSKH or PMP media in Europe. You can also use RPMI and CMRL 1066. Now, your pathologist may tell you that we don't have the special media to grow Lyme spirochetes. That's the BSKH or the PMP media. We're a small hospital. We don't have it. To them, you say, every hospital on the planet which does tumor work has tissue culture medium, and RPMI and CMRL 1066 are such media. They're maintained in the refrigerator in the pathology lab. When a leukemia case comes in, it goes into one of these, RPMI and CMRL 1066, to do special molecular studies. If you don't do those studies, you're guilty of pathology malpractice, because you must do molecular analysis on leukemias and lymphomas. Lyme disease spirochetes will grow in RPMI and CMRL 1066. The variable is that they won't come out as spirals, they'll come out as cystic round forms. When they grow and they're isolated in round cystic form, place it into BSKH and they will revert to spiral form. Cultures are difficult because the organism is fastidious. That means it's picky. And there are ultra fastidious organisms that are even beyond picky, and they will not grow in the ordinary BSK medium. We call them viable but non-cultivatable, and that's V, B, and C. I believe that many of the species that cause trouble in humans are very, very difficult to grow in the laboratory with the best of culture media conditions. We need to improve our technique and enhance the culture mediums to let these organisms grow, and we'll discover more and more species of Lyme disease causing spirochetes other than Borrelia burgdorferi, Carinii, and Afzalii. We'll start to pick up the curtain back eyes and the Valsanii eyes and the Besetti's in our patient population. Mixed infections are a problem because at autopsy there's always staph or strep or anaerobes mixed with any other bugs, and if Borrelia is mixed with these mixed infections will grow fast and overwhelm the culture medium. The Borrelia won't have a chance to get the nutrients and will not grow. To remove unwanted contamination from these organisms, serial subcultures are done, selective antibiotics are added to the medium, and you can filter the material through 0.2 micron pore filters. Spirochetes and DNA from the Borrelia will pass through the 0.2 micron filters. These microbes will not. Kinetics of primary growth, they grow slowly, and they have to become lab adapted. Sometimes it takes months, 3 months to 6 months, or up to a year for some spirochetes of the Lyme type to adapt to laboratory growth conditions. So don't throw the cultures out after 3 weeks or 6 weeks. Maintain them, observe them, examine them, and you will be rewarded with organisms. It will surprise you. Collagen added to culture medium helps to enhance growth, enhance the yield, and cystic Borrelia may be recovered in pure culture. These are the round ones that I showed you before. Silver staining I will discuss in detail in Oslo and in London. Excuse me. Fresh blood analysis, Dr. Bulsick and Dr. Lani will deliver lectures in Oslo and perhaps in London and describe their techniques for fresh blood analysis for Borrelia. These are very exciting new techniques, and they will help us in diagnosing difficult to diagnose conditions related to Borrelia infection. Antibody negative Borrelia scenarios, there are many. You'll say the blood test is negative, therefore it can't be Borrelia. I will discuss many of the reasons why antibody negative Borrelia are real. Excuse me. And we will discuss the mechanisms for antibody negative but biologically positive Borrelia infections in the human host in various diseases. So you can have Borrelia infection with negative blood antibody, negative cerebrospinal fluid antibody studies because of various complicating factors shown here among the complicating issues. Darkfield examination for Borrelia is helpful. It's always done in a dark room, and I won't go into further detail about this. I'll describe this in Oslo and London again. It's an art. It requires practice. It requires a special microscope, special Darkfield condensers, either oil or dry, and I will go over the quality control issues in Darkfield examination for Borrelia. Searching for Borrelia in tissue sections. I've written papers on this. The most recent one is in the European Journal of Clinical Microbiology and Infectious Disease, which you may refer to, and I describe the staining of such organisms and the need for controls. You must always have a control, paraffin, wax control, containing lots and lots of Borrelia, so that when you do a stain and you get a negative result, you'll know that the stain worked on the positive side with the control. If you do a stain without a control and you get a negative result, you don't know whether it worked because you don't have a control to go back to. Doing stains without doing controls is pathology malpractice. I will describe miliary, minimal, or focal disease and tissue reactions in Oslo and London. I won't go into it here. Host responses, I will describe them in London and in Oslo. There are various types, various scenarios. In the brain, I just call attention to microglial only, and that's the best example of an inflammatory reaction which doesn't look inflammatory to the ingenue. Present in some dementia cases. Attributed to our knowledge is summarized here. Dr. DeRay, of course, passed away in 2012. Dr. McCloskey, Dr. Ligner, and others in the next two tables. All major contributors to our knowledge of autopsy-related Borrelia practice. Notes from Dr. Noguchi. Now, Dr. Noguchi is my personal model for excellent spirochetal investigator, my inspiration for my work. Over 30 years, he discovered that Treponema pallidum was present in diseased human brain and autopsy general paresis, which is dementia of syphilis. Prior to Dr. Noguchi's success, people had tried and failed to find the spirochete of syphilis, Treponema pallidum, in general paresis dementia tissues. Noguchi succeeded, and the textbooks were rewritten. He triumphed over Dr. Max Nonne, N-O-N-N-E, in Germany, who denied that the spirochete of syphilis could still be around 20 or 30 years later after initial infection and cause dementia. So Noguchi proved that that could happen, and he gives us some advice. In the hitherto vain attempts to find Treponema pallidum in tissues, this does not mean the spirochete is never present. Here's the sentence that we must repeat again and again. It may have assumed forms so far unknown to us, such as cystic forms. He didn't know about cystic forms. They're real. They cause disease. Or may have located in places where it has not yet been sought or where it is hard to find. And Noguchi was right about that too, because syphilis could be present only in the anterior aqueous fluid chamber of the eye and be present nowhere else and cause blindness. And that is an expert in hiding in the body. Borrelia can do what syphilis can do. Anything that syphilis could do, Borrelia can do. That's my personal mantra. So this is the beginning of lifelong learning, the conclusion of the lecture. I apologize for my cough.